Dr. Ashish Sharma is heading the medical retina department at Lotus Eye Institute, and he has around 100 publications based on anti-VEGF. So it is a massive number and a massive experience that he has. And over to sir for the.
So the topic of IC was, immunogenicity, whether it is, it's kind of a hurdle for us in further progression. So that's what, during introduction I said, we had wonderful molecules like abicipar. Abicipar was a wonderful molecule, means could not get approval, means after phase 3 in spite of a lot of measures being taken. So BROLUCIZUMAB, I means always say excellent drying, excellent efficacy, but just because of, incidences of inflammation, it's not taking off the way it could have just taken off. So, means I would talk about peculiarly ocular vasculitis, that why this has become the talk of the town, and why this is important. So, means we have been trying to understand biologics, biosimilars, and all these molecules since last 4 to 5 years extensively, and thank you, Nilesh. So we have been trying to understand these molecules since last 4 to 5 years, and this is our contribution in the form of various publications. I would definitely like to mention this group, which has been very, very helpful since we have started understanding and putting it on paper in the scientific forum. So means a big thanks to all of them. And as far as my financial disclosures are concerned, these are my disclosures. So why occlusive vasculitis was highlighted? That's the first question that I should ask. Because it was never observed as an adverse event with existing anti-VEGFs in all the trials, if you see from the beginning. And other thing is, it was sight-threatening. So that's why it was highlighted. And if you look at the day of celebration in 2019, 8th October, when the drug was launched, after that few months, there was alert on safety from ASRS with 14 cases of vasculitis and 11 cases of occlusive retinal vasculitis. So then Novartis was responsible, and they had a SRC. SRC, what it did was, the question was that why it was not picked up during the Hawk and Harrier. So then they went back and they checked all the cases carefully, which were not reported as occlusive vasculitis, which were reported as just the intraocular inflammation, just to check whether in that cloud of intraocular inflammation, we had some kind of vasculitis there. So after studying that data, it was revealed that incidence of retinal means vasculitis and retinal vascular occlusion was higher than the trial. It was approximately 2.1% compared to the trial, which was 1%. So there was a disconnect. So then Novartis updated their label. For example, if you look at their label information in 2019-10, then retinal vasculitis was not mentioned. But if you look at the data and label in 2020, it was included after the SRC report. So this was the paper that we published, that there was definitely a disconnect from the trial to the real world. And we cited some of the reasons that why the disconnect was. Now, means I would just straight away come to some of the representative cases for clinicians or anybody who is there who just want to see. Look at these cases, the kind of whitening because of the occlusion, retinal whitening. But if you look at the OCT, right from the B, D, and F images, look at the efficacy, just brilliant. Efficacy was so brilliant, but occlusion was something which was worrisome. Again, if you look at the FFA, in this case, multiple occlusions, dye is not going through further. And similarly, in all these cases, if you see, again, occlusion, arrows are pointing out, FFA showing the dye is not going further. But if you look at the OCT, such a drying, that kind of impact we have never seen with any kind of molecule. Again, this case, again, FFA shows a lot of occlusions at multiple sites. So these are the cases were from my very good friend Caroline Bamal. So if you look at the structure is quite different. You have power packed, 22 times concentration compared to the other drugs. So probably that was kind of a double-edged, means you have more molecules to give you more efficacy, but means I was probably not that tolerant towards that many molecules. Question was retinal vasculitis and retinal vascular occlusion. Why? Eye is an immune privileged site. So why do you have this vasculitis and vascular occlusion coming in? Mystery has not yet solved. Still it's a mystery. So what we did was, because we have been working with biosimilars and biologics, trying to understand, means when we had few events with the Razumab, we have been publishing since that time and trying to understand from basic science that what happens. So this is something like, when you open an old wine bottle, that is more sweeter. So this is the answer that we found, and if you look at the paper which was published in 2019, way before when brolucizumab was launched, we proposed that ADA could be something which need to be looked upon, anti-drug antibodies. And after that, what happened? We proposed this hypothesis in this paper that type 3 is something which could be responsible for this vascular occlusion, and possible ADA testing before occlusion might be a way to go. And the same thing we proposed to the designer of the molecule, Doug Saur. So Doug Saur, means in a meeting I discussed with him, probably pre-injection ADAs were too high. He said, Ashish, I agree with you, but the problem is, means they were all non-specific. They were all non-specific segments from where the ADA was generated. And to get the direct correlation and to establish ADA testing, pre-injection is a difficult task. If I know that, in every case, ADA is high, induced ADA is high, then inflammation is happening, then probably, I can push it for. But again, that direct correlation was not coming in. So that is why ADA testing is restricted still till the clinical trials. It has not yet gone into, pre-injection phase. So this was the paper which was contradictory to our hypothesis from a very good friend, means Thomas Albini, who works in uveitis at Baskin-Palmer Institute. So what they did was, in one case which had retinal vasculitis, they took a sample from vitreous. And in vitreous, they found CD4 and all the markers which belongs to the type 4 reaction. So they proposed that probably the type 4 is the one which could be responsible. Then this is an editorial that we published. We re-emphasized our stance and gave a reason that, all right, but means we really cannot believe that it's just the vitreous that you can find an answer. If you really want to see, because it's the phenomena which is happening in the vessel wall. So you really need to look at the vessel wall if you really want an answer, biopsy of the vessel wall. So we are still, means sticking to our hypothesis is probably type 3. But we could be very well wrong in that. Now, if you look at the Merlin data, which came after 1 year, which showed that after monthly injection, brolucizumab inflammation rate was approximately 9.3%, which was pretty high. So after that, after Merlin data, companies stopped all the trials which were giving monthly injections after initial loading doses. Now, if you look at this, and if you look at our paper, we proposed it way back when we proposed our hypothesis and the mitigation plan. We proposed it in November 2020 that monthly injection is not the right way for brolucizumab. So that's what happened over when later Merlin results came out. So now what? Now the question is, now do I use this drug or no? I use this drug, but it is not my first line drug. It has a great efficacy. I use it in given up cases. So because I definitely want to utilize the drug, so there is a space for this drug for me, but unfortunately not as a first line drug. So if you have, means fortunately or unfortunately, any kind of incidents, these are the protocols that were given by our group and by Baumal group, so that you can refer. This is again our proposal. From our learning from biosimilars, we propose that bio-better could be something which can change brolucizumab. Now I'll tell you that why Novartis is not going through the biosimilar route, because bio-better route is not clear in the world. Bio-better, if you want to design, means what as a naive understanding, an understanding of biologics, I feel probably, industry leaders are there. Alok is sitting there, has a great understanding. So, means what I feel is if you can reduce some kind of molar concentration in this molecule, there is a possibility. You might compromise on some kind of efficacy, but there is a possibility that molecule will survive. Unfortunately, FDA and EMA, they do not have a clear pathway for bio-betters. They consider them as an innovator molecule, and they have to go through the entire process all over again. So nobody wants to do that. So if you look at realistically, PDS, port delivery system. Port delivery system is a bio-better. But has it been, known as a bio-better? No. It has been known as a new drug. But if you look at the port delivery system, it has a better delivery mechanism. It has a little, different concentration of means ranibizumab that they use in. Similarly, if you just look at Lucentis was essentially a bio-better. It was a bio-better of bevacizumab. It had just the FAB portion. They just cut down the FC portion. So it means if you have some mechanism by the FDA and EMA that bio-better can have some abbreviated route, drugs like this would not die because these very important drug. So I still say the brolucizumab story is not yet finished. A wonderful drug means I use it as a third-line drug. So probably we'll learn more and more. So I'll keep it short here now, and because we have two legends sitting with us, so I think discussion would be more fruitful with them rather than me speaking. Thank you so much.